So the first special test that we're going to do is the internal rotation resisted test, and that'll kind of help me differentiate what I think might be injured. So if the internal rotation and the external rotation are pretty equal in strength, then I'm thinking it's more of an extra articular injury, AC joint, or something like that. If the internal is greater than the external, then I'm thinking it's possibly more of a rotator cuff tear. And then if external is greater, then I'm thinking it's more of an intra-articular thing like a slap tear or something like that. So first what I'm going to have to do is have the patient come to that 90-90 position and bring their arm up just a little bit. And then I'm going to say, I want you to meet my resistance and don't let me move you from this position. So I'm going to stabilize here, have you sit up nice and tall. Okay, so I'm just going to apply a little force. Good. And then we're going to do the same idea going the opposite way. Again, compare. So if I'm suspecting a rotator cuff full thickness tear, then according to Park, the best test cluster for that is the internal rotation resisted test, which we just performed, the drop arm sign, and the painful arc sign. So for the painful arc, I'm going to have him sit up nice and tall, bring that arm up a little bit into the scaption plane and up. If he has pain only between about 80 degrees to 120, and then it gets better as he gets past it, and then clicks into that painful range again, and then relieves it, then that's a positive sign. The only other one we have left for that one is the drop arm sign. So what I'm going to do is I'm going to passively bring his arm into abduction, just above 90, and then I'm going to ask him to slowly lower that arm back down. If he can and it's not painful, then that's negative, but if it just drops without any control, then that's positive. So between the three of those, 3 out of 3 has a positive likelihood ratio of 15 if they have all 3 positive. To rule out, according to Cook, the ones with sensitivity about 97% for weakness is the full can versus the empty can. So what I'm going to have him do is bring his arm out just a little bit, about 30 degrees abducted, and then rotate it all the way out, so a little more abducted. This is the full can. What I'm going to do is apply a downward force, assessing for pain and then weakness comparisons to both sides. I'm going to repeat the test. I'm going to have him bring it all the way internally rotated, and then downward force again. If I'm suspecting more of a rotator cuff tendinopathy, according to Park and then confirmed again in Biederwolf, the 3-item test cluster is pretty similar. It's still the infraspinatus muscle test, which we did first, and it is still the painful arc, which we just performed, but instead of the drop arm sign, it would be the Hawkins-Kennedy test. So what I'm going to do is I'm going to bring the patient's arm up, have you sit up nice and tall, and then I'm going to bring his arm down into internal rotation. If that is painful, then that would be considered a positive test. And then bring it back down. If 3 out of 3 of those are painful in this, then the likelihood ratio is 10.5. As far as ruling out, actually, according to Cook and Biederwolf, the negative drop arm sign is has a sensitivity of 100%. If I was thinking it was more of a slap tear, the 2 tests that I would use would be the biceps load 1 and 2 because they have the best sensitivity and specificity. Sensitivity is about 0.9 and specificity is about 0.97. I found that in Cook and Biederwolf as well, that article. So their patient's going to be in supine. For biceps load 1, I'm not going to worry about 120 degrees of elevation, just about that 90-90 position, a little bit of external rotation. And then I'm going to have the patient try to bend their elbow and resist them. So go ahead and try and bend that elbow. I'm going to resist, and we're checking for pain or any apprehension towards doing that. For biceps load 2, it's the same thing. I'm just going to bring to about 120 degrees of elevation, and same thing, I'm going to have them resist in. Good, and then assess. If I was suspecting more of AC joint pathology, the test item cluster that I would use would be AC resisted extension, cross-body adduction, and the active compression test. And that's again according to Biederwolf, and there's some text by O'Brien as well. So what I'm going to have, if 3 out of 3 of those are positive, the specificity is 97%, but if only 2 out of 3 are positive, the sensitivity actually is the highest at 80%. So first what I'm going to have you do is sit up for me. The active compression test, I'm going to have you bring your arm in front of you and up, and then downwardly rotate, yep, and then bring it just a little bit across your body. And from here I'm going to apply a little bit of a downward force. If there's pain on the top of that shoulder, that's more AC joint. If it feels like it's deep, that might make us think it's a little more labral pathology. For the active extension, I'm going to have a patient come up to here. I'm going to stabilize, and then I'm going to just resist. I'm going to have you bring your arm across, back towards me, and I'm just going to resist. Again, checking for pain at the top of that shoulder. Finally, cross-body adduction. I'm going to have him bring it across into horizontal adduction, and then I'm going to apply just a bit of a posterior force. Next, we're going to look at the motion of the elbow. So the first one we're going to do is you're going to hold that upper arm, and we're just going to go into flexion passively, and then applying a little bit of overpressure. To do a bit of a combined motion, you can do supination and abduction with flexion, and you can also do adduction with pronation, and check there. To go into extension, you may need to either support here or use a bolster to kind of elevate that top part of the arm, and you're going to go right into extension as much as you can, and then a little overpressure. Again, you can do a little bit of it into the abduction versus adduction, assessing for pain. For humeral radial and humeral ulnar mobility, if you're applying anterior posterior force, you're working your way more into flexion, and then if you're applying a posterior to anterior, it's more into extension. So first we're going to do supine, we're going to do those anterior posterior forces. What I'm going to do is support his upper arm with my other hand, and I'm going to get my fatty part of my thenar eminence on the ulna, the anterior portion of the ulna, and apply that anterior posterior force. You can do the same thing with your other hand on that anterior radial head. That's a little more sensitive, so just be careful. Make sure you're getting some strong contact points, and you're just going to apply the anterior to posterior force. You can do the same thing in a little bit more of flexion, working more into that movement. Then I'm going to have my patient flip over for me. We're going to apply a posterior anterior force, working more into extension for both of those. So I'm going to support here. You're going to kind of get them in that loose pack position. I'm going to start with the radial head, and I'm going to get on that posterior aspect of it and apply that posterior anterior glide. Again, you can work into a bit more extension, just watching, making sure you've got a nice stable base. Switch your hands. You can do the same thing on that ulna, posterior to anterior. Next, we're going to look at proximal radial ulnar mobility. So I'm going to have a patient sitting, relaxed, elbow bent, and you're going to do a medial glide of the radial head for supination, and then a posterior glide for pronation. So what I'm going to do is I'm going to get on that fatty part on the medial border of the radial head. Again, it's kind of a sensitive area, so be careful. And I'm going to provide that glide, and you can kind of check as it moves into supination how that glide changes. Same thing. Working into more of a lateral glide as you work your way into pronation. The next things that I'm going to have you do is I'm going to have you lay down. We're going to look at ligamentous stability. So I'm going to have the patient lay down for me, and we're going to check the varus and valgus stability of the elbow. So I'm going to support the arm completely. I'm going to get my hand kind of all along that medial border, and I'm going to use my body to induce a valgus movement and assess that UCL stability. And you'll assess it with like full extension and then a little bit more flexion. And then you'll do the same thing. I'm going to stabilize with my other hand this time and get along that radial border. And same thing, assessing that radial collateral ligament. The only other one you can do is you can sit up for me. We're going to do a moving valgus stress test. So I'm going to have the patient bring his arm up. I'm going to induce abduction, about 90 degrees abduction, sit up tall for me. A little bit of that valgus motion, external rotation, and then I'm going to straighten his. To help differentiate between pronation and supination, that can come from proximal radial ulnar joint, distal, or the carpals. So we've already looked at proximal radial ulnar joint before. If we want to look at distal, what we can do is stabilize the elbow and the forearm and get right on that distal radial ulnar joint, and then move them into that pronation and supination, assessing for pain and increased mobility. As you work your way up, you can then stabilize that distal radial ulnar joint and get on that first row of carpals and do the same thing, working your way into that pronation supination, checking for any change in their symptoms. Same thing, you get on that proximal carpal row to look at the mid carpals and working your way into pronation and supination.